is a high intensity laser. Now it's very common, the therapists to use Shockwave and also the laser, the combined treatment. Now in Hong Kong is more and more people to use. So I think it's time to provide official training to everyone to see how to combine the two devices to achieve a better result. So let's start to the training and give a big hand to Dr. Ella. Thank you.
Thank you for having me again. We're going to have a quite intense night, 3 hours, and have to go and run through a lot of material. And I would like to do some clinical stuff too, some treatment and examination. So for those of you who haven't seen me before, my name is Anders, and I've been a chiropractor this year for 25 years. So, and early in my career, 17 years ago exactly, I started working with focused shockwaves. And at the same time, I actually started working with the low-level intensity lasers, which I didn't find very useful. But within the last few years, we've actually had these new devices, high-intensity lasers. And that's better. And they have each their course in managing these sports injuries in the lower limb, which I want to go through tonight. So I'm just going to see if this works. Here we go. In Denmark, I work in a clinic where we are 7 chiropractors and 3 physiotherapists, so we work very closely together. Diagnosis and treatment is one thing, but rehabilitation is very, very important too. So everything I'm going to tell you about tonight here, about treating these diseases, they all have to be followed up with rehabilitation to be successful. That's why you have to work together in a very close network, so have a good physiotherapist and orthopedic surgeon with you, so you know what you can actually do in your daily practice. I'm also the chairman of the Danish Focus Shockwave Society, where we are medical doctors and physiotherapists and chiropractors, and we just did a follow-through of all the literature on the focus shockwave. So that's what I'm going to introduce to you today, all the new studies which are there, which you can use in your daily practice. I want this to be as clinical as possible, so if you have any questions on the way, please raise your hand and stop me if you don't understand what I'm saying, so we can get through all the clinical stuff. So I'm just going to run through very briefly the literature and the mechanisms behind the focus shockwaves and the high intensity lasers, how they differ and how they can be combined in your clinical practice. And I'm going to present this PizzaWave 2 device. We have 3 of those machines in our clinic, and we also have this new BioLaser 2 high intensity lasers in our clinic. And we work mainly with the acute injuries with the high intensity laser and the more chronic injuries with the focus shockwaves. But often in the very complex cases, we actually combine the 2 treatments. So we use both therapy units at the same treatment course. So as you can see, I'm going to run through some, after the theoretical stuff, I'm going to run through the knee area, how to examine it, and clinically which points are relevant for you to treat with these 2 devices here. And then I'm going to go into the foot and ankle, and then I'm going to run through the hip area, both the lateral pain, the posterior pain, and the groin pain, just to give you an idea of how to diagnose it and how to treat it with these 2 devices here. So these are the ones I'm going to present for you today. And let's start out with the PizzaWave 2 and the technology behind that. As I told you, I've been working with focus shockwaves for 17 years. So I've been working, I have a Storz and a Dornier machine too, and I have these PizzaWave technology too. So this is the newest technology on the market, and the thing with this is that it is laid out a little bit differently. The headpiece here consists of a double ceramic layer of these ceramic plates, and when you put a lot of voltage into these, they can produce a very powerful focus shockwave. So this device here is the most powerful focused shockwave on the market right now. So it produces a higher pressure and it produces more energy per treatment. For both devices, as you probably know, just like with rehabilitation, you want to give as much energy to the tissues in a short period of time. And with this device we're actually able to do that, and with this high intensity laser we're also actually able to treat in a very few minutes with a high energy outload. And that's going to cause some other responses for your chronic patients and acute patients too. So when we talk about focused shockwaves, we work with this therapy zone here. And what we have to know is the pressure field. And what does that mean? That means how much pressure can each machine produce. And as I told you, this machine produces a steeper pressure phase, so the shock waves are going to be adapted a different way in the body than other machines which are focused. Then we work with this energy flux density, as you can see here, and that's just a term of how much energy there is in this therapy zone when we treat the patient. And the total energy is how many shocks per treatment we give the patient. With this new technology, these focused shock waves are very densely orientated within the treatment zone. So the patient will actually perceive pain quite a lot when you use this device here. And that's what you want to do, because you want to treat not only the patient's degenerative disease or tissue, but you also want to pain modulate the patient. The good thing with this device here is that it has two therapy units, or therapy heads. We have this focused device here, which is over here, which produces this like cigar-shaped therapy zone. And unique for this device here is that it also has a linear headpiece, where you have a very large linear shockwave zone, which can produce a moderately high energy level, but you can treat a very large area every time you treat the patient. So how do shock waves actually work in the body? And it works like any other therapy. We actually put a mechanical stimulus into the body, and the body tissues will then react chemically and neurologically to these stimulus. And we call that mechanotransduction. That's where we actually are causing a lot of genetic and biochemical activity and neural modulation when we use these shock waves. And depending on how doses we use, we actually can produce different kind of actions in the tissues. So we have two ways that shock waves, focused shock waves, work. And let me just tell you, radial shock waves are not going to be covered tonight. They don't have this effect on the tissues. It's only focused shock waves which have that. So it's very important that you know that. So we see a lot of hyperstimulation of the painful nerve fibers in the tissues, and we see modulation of the neurotransmitters. So after a few treatments, we can actually reduce the patient's pain, even though it has been chronic for a long time. We also see reduction of these painful nerve fibers in the tissues after 3 to 4 treatments. And then we see a modulation of the activity of the neurotransmitters. And we do not only see that in the periphery at the tissues that we treat, but we also see a neuromodulation at the spinal level and at higher cortical levels. So when you give a treatment, you're going to stimulate the whole pain pathway. And that's why it's very important that the patient actually perceives a little bit of pain when you treat them, because that pain is going to dissipate during the treatment, and that's going to pain modulate them. So even though they've had pain for half a year, 2 years, then if you use this device properly, after 3 or 4 treatments, you can probably halve the pain of the patient. And that's very convincing when you have a patient in who had a chronic condition for a long time. We also see a metabolic activation of these shock waves. When shock waves were invented in the 1980s, they were used to, and are still used to, treat renal stones, where you actually shatter these renal stones, in fact, instead of operating them. So it's non-invasive therapy, and every large hospital has a Shockwave device to actually treat the renal stalls with. But when they started treating up through the pelvis, they saw the scatter radiation who hit the pelvis. They actually saw a buildup of cortical bone. So moderate doses of shock waves are very, very, very effectively at regenerating tissues in the human body, and especially bone. The more vascular the tissues are, like muscle, synovium, and bone is very, very actually vascular, the faster response you will get in bone. So tendons, which are not very, or ligaments, which are not very vascular, they respond slower, but they still respond well, but it takes longer time. So we see a lot of chemical changes in the cells, where we see mainly cell proliferation, and we see migration of these, like say, basic stem cells which we have in the body, which can convert to fibrous cells, bone cells, or other cells that are needed in the tissues that we treat. We also see bone morphogenetic protein, which is like a growth factor, which is also stimulating growth and healing and regeneration in tissues. And most importantly of all, we see this production of nitrogen monoxide, and that's a precursor for capillaries in the tissues. And why most chronic conditions don't want to heal up is because we don't have microcirculation in tissues. And when we talk about, like say, chronic sports injuries, like tendinopathies and other muscular tissues, researchers, they have a limit where they say before the age of 30, most patients heal up by themselves or by conservative treatment. When you're older than 30 years old, all the body processes that slow down for these, like these sports injuries. And why do they do that? Above the age of 30, we see a genetic bomb hitting the body, and approximately we see a reduction of small capillaries in tendons and attachments of muscles and tendons at that age. So in my age, I'm 52, I don't have to do very much to actually get an injury, and my body will have quite a hard time to heal up. So we have to stimulate the healing processes in an artificial way, and we can actually produce new blood vessels by using the focused shock waves. I was at a conference 2 years ago out here in Asia too, where at the big Taiwanese university hospital they did research on focused shock waves on diabetic wound healing. So they had about 700 patients, which they parted up in 2 groups. And the one group which received shockwave treatments, 3 treatments, they had a better healing rate of 70 to 80% compared with the control group. So even diabetic patients which don't have any blood circulation, we were actually able to establish new blood growth, blood vessel ingrowth in those tissues. So even in very, very chronic conditions, this can actually produce very, very, very aggressive new growth of vascular support for these tissues. So when we want to simplify all this, what do focused shock waves do? They modulate pain, and they modulate pain not only where it's actually processed, but also where it's sensitized at the spinal level and at higher cortical levels. So when you administer shockwave therapy, you have to be able to increase the energy levels to the level that you want to use, but also that the pain level that the patient can tolerate. They have to actually perceive some kind of pain, unless if you want to have the right result. We also done research where we had patients receiving focused shock waves which were anesthetized and non-drugged. And the group which didn't receive any anesthesia, they were actually responding much better than the ones who were drugged while under treatment. And that's because we are causing this central stimulation at the spinal level and the higher cortical level. And we know all patients, especially back patients and sports injuries, the longer they have the pain, the more sensitized the pain gets. and they have to take more and more painkillers, but the pain still persists and gets worse and worse with time. And then we also have tissue repair. That's another focus area of the focus shockwaves, and it causes tissue repair in all human tissues. Not only bone, not only cartilage, not only fibrous tissue, but also in synovium and all of the tissues that we use them in. And that's been established like in the literature for a long time now. So what doses do we need to use with this device here? We have the two therapy units that I told you before. So the linear device, we have to use these energy levels, 0.04 to 0.16 millijoules per square millimeter. And with a more focused one like this, we can actually go higher up and treat the tissues in these intervals, 0.2, 0.4 millijoules. And you don't have to go higher than that with this device because the energy field is very condensed and very effective. And with these doses, you cannot cause any harm. So it's totally safe to use it for your patients. We also talk about how many shocks per second do we have to use. And there's been a lot of controversies in that in the literature, but we know that the more shocks per second that we can actually fire at the tissues, the more energy we can deliver to the tissues in a short period of time. And if you have a device which can actually fire 8 times, can fire 8 times a second compared to one which fires 2 shocks per second, then you'll have a totally different patient response, both in pain modulation and in regeneration of the tissues. That's why this device is my preferred one, because I can deliver a lot of energy in a short period of time. So how many treatments are necessary? Normally you should treat for fibrous tissue and bone tissue about 3 to 6 treatments. You can do 2 treatments a week or once a week, depending on how chronic the condition is. And for more like the musculoskeletal pain, like trigger points, like small fiber lesions, we have the same treatment protocol too. Most muscular problems only need about 3 treatments, then they'll regenerate by themselves very fastly because they're so hypervascularized. So, how does this new device, high intensity laser, work? This little neat machine here, it can actually produce this high intensity laser. So what is high intensity laser? Oops. Let me just go through here. Okay. When we talk about laser, we talk about photons, and they actually are measured in nanometers for their wavelength. And high-intensity laser has 2 working mechanisms. We have these photons actually going into the tissues, the superficial tissues, and causing some metabolic activation. And we also have a thermal effect coming in from the light source itself. So we see heating of the tissues, which also have an effect. We talk about this treatment window, where these wavelengths between 400 and 1100, that's where you actually can penetrate the skin and go into the tissues and cause some biological response. So above 1200 and below 400, you won't get any effect. And this device here can go up, or has a wavelength of 940 millimeters, and that means that it can actually penetrate quite deep. Up to 3 centimeters, you can get a very good response, both from the photodynamic effect and from the thermal effect too. So this is also a very simple device. We only have to put the settings on how many watts we want to actually treat the patient with, and then we have to put the treatment time down, how many seconds do we have to treat the patient, and if you multiply those two, you got the measurement in joules, which is the total energy of per treatment. So we have some small guidelines for this. Because it's a high intensity laser, it can cause a lot of heating at the tissue, at the skin level. So you have to move the probe when you increase the wattage of the treatment. And you also have to not pointed into people's eyes because it can cause damage. So you always use safety goggles when you treat your patients, and the patient also has to have one on if you somehow should slip with your laser and probably point them into people's eyes. You don't want to do that. Luckily, this device is made so good that it has a foot switch. So you take up the device, put it over the treatment zone, and you turn it on. And when you finish it, you take your foot off the foot switch, so you shouldn't be able to do any damage with it. So there's a few contraindications to this. So if they have a serious medical condition, you just have to take that into consideration before you start treatment, but it's only a relative contraindication here again. What's most important is that because of these high-intensity lasers are so powerful, it causes a lot of heating at the skin level. So the darker the skin, the quicker it's gonna heat up. Or if you have a tattoo, it's gonna take a few seconds and it's gonna become very, very warm. So you have to decrease the watts that you use then. Or you have to move the probe very fast so you don't get that. With laser, high-intensity laser, it's a very, very good device if you have acute injuries. Sprains, strains, swellings, and other acute sports injuries. You can use this device immediately, where you wouldn't be able to go in manually or with any other therapies. And you'll see a very quick effect, both pain modulation-wise and swelling in the tissues will also be reduced quite fast. So this is the device. It's quite small and simple to work with. If you want to treat deep in the tissues, then you have to use a lower wattage and a longer time span. If you want to treat superficial in the tissues, you can use a higher wattage and a shorter time span. That's the general idea when you treat. So if you use very low wattages, like under 3 watts, you can actually hold the device on. But if you use higher, you have to move the probe. And you move it about 1 centimeter per second. And when you treat, you have to think about a playing card. Then you have to treat in that size area when you treat the patient, just to distribute the thermal heat and the photodynamic effect. So what does research show with these high-intensity lasers? How do they work? And it seems actually to work a bit similar like the focused shockwave. It increases metabolism, but it also pain stimulates, inhibits in the tissues. So you will have both pain reduction and you will have increase of circulation and decrease of swelling in the tissues. So that's where it's very convenient to use in all acute sports injuries. With the old low-intensity lasers, the patient didn't feel anything when we used those lasers. With the high-intensity lasers, they will feel a response under treatment and after treatment. They will have less pain, and often they will have, just after one treatment, less swelling at the same time, if you use it properly. So that's a very, very good tool to have if you have more acute injuries. So we have two effects of these high-intensity lasers, and one of this, the photodynamic, the photons going into the tissues and causing these chemical effects in the tissues. And then we also have the photothermal effect here, which is actually a quick warming of the tissues, which is lowering the resistance in the muscle tissue and in the vascular tissue, and increasing the water, decreasing the water content and improving metabolism. So what's the evidence behind the focused shockwave? How well does the literature show that it works right now? And I've just been going through all of it with my colleagues. And if we take the focused shockwave treatment here again, and we look through all the meta-analysis and randomized controlled trials, then for chronic tendinopathies or bone lesions, focused shockwaves has the highest evidence right now in medicine. It beats medical therapy in form of injectional therapy and and pain medication, and also beat surgery for these chronic tendinopathies. So it's actually the first choice in chronic tendinopathies and bone lesions is to use focused shock waves. And it has to be followed with rehabilitation. Otherwise, it can relapse and come back again. So it's very important that you strengthen the tissues after you have pain modulated them and after the tissues have started healing up again. So if you look at each individual study for the upper limb and lower limb, we see that the stronger the focused shock waves are, and the more treatments you give, the better results you actually have. So within these levels here, 0.12 to 0.34, we see the best effect. And in general, you'll have a better effect with 6 treatments than with 3 treatments. So you accelerate the healing by using more treatments. More than 6 treatments are rarely needed in the literature, so that's where you actually have to plan your treatment in. With bone lesions like non-unions, pseudoarthrosis, stress fractures, only 1 or 2 treatments are necessary and you have a 100% heal up rate. 100%. They all heal up. And there's quite a few very good randomized controlled studies in the literature here. I've treated hundreds of stress fractures mainly, and all of them have healed up after 1 or 2 treatments. Sorry? Cartilage I'll get into. It's a new area where we have been doing some research, and we have some quite good research on the lower limb now, on cartilage lesions. You need some form of understanding when we go into it, so I'm just going to talk in more detail here. So these are the areas where we have very strong evidence that focused shock waves work. And for the lower limb, it's especially lateral hip pain. And what's lateral hip pain? It's just pain on the outside of the hip. So it encompasses osteoarthritis, labral tears, tendinopathies, muscular problems. So in all these areas, it has an effect. It also has a good effect on jumper's knee, patellar tendinopathy, and it has a very good effect on Achilles tendinopathy and plantar fasciitis. Trigger points has also been established where it's actually very, very good and powerful at getting rid of them. 2 to 3 treatments with a high dose and they're gone. And especially the deep lying trigger points in the hip, back area, in the thigh area, in the calf area, where you can't get to manually, it's very effective. With the high intensity laser, because it's quite new, there are less studies, but there's about 30 to 40 very good randomized controlled studies. The evidence is not as high because we haven't got that many studies yet. But still, there's a few meta-analyses, and they actually conclude primarily that it both shows significant improvement in pain and disability scores. Most of the studies have been done on the upper limb and the neck and back area, and few on the lower limb. But we can still conclude, especially from empirical value and experience, that it has the same effect in the lower limb. So, which device should I invest in? Or which should I use? I use primarily the high-intensity lasers for all acute injuries, sports injuries, and also back injuries. All acute injuries, because of the photothermal or photodynamic effect, you will see some relief. For all chronic conditions, I use the P2 2 here, because we have some tissues which have regenerated, and we have some ingrowth of these nerve fibers that we want to get rid of. And with complex areas, where we have a chronic osteoarthritis around the knee, with tendinopathy and changes in the joint capsule and the ligaments and in the synovial tissues, I use both. So I start treating with the focused shockwave, and to get rid of all the other inflammatory material, I follow up with 2 to 3 minutes with a high intensity laser at a high voltage. So, as you probably know, if you have a tendinopathy, it's not just a tendinopathy. there's other things going on there. So if you actually start overloading some tissues around the knee, let's say the tendon, then you'll have some inflammatory products going around and affecting the underlying joint, underlying synovial tissue, and also the ligaments. When the body tries to repair itself in closed joints, it actually produces these small protein chains, which you can see on high resolution ultrasound. You can see them traveling around the tissues, and it does not only try to heal up the tissue that you overloaded, but it affects all the other tissues and causes adhesions and pain. So by just treating a localized little anatomical area won't give you the same effect if you treat the whole area. And that's where we can actually, both with this device and the linear device with the focused shockwave, we can treat a very large area. And if you have a lot of inflammation, inflammatory process and palpation, tenderness around the joint, you can follow up with a high intensity laser to actually get rid of that inflammation and edema too. And that's where we see a great result clinically, that with these more chronic cases or very acute cases where you have ligament strains, if you use both devices, you get a whole different and fast result. So, what clinical indications do we have? The literature has shown us that we have high evidence on chronic tendinopathies and bone disorders. We have less evidence on the other ones. But a lot of research is coming out now. A lot of hospitals are actually dedicating the researchers for this. And there's a few studies done here, and the whole literature run through, that with muscular lesions and trigger points and small strains in muscles, the evidence is quite high that it can repair that very, very fast compared to normal conservative measures. So we know when we have an injured joint or overloaded joint, we have some muscular compensations around that. And what does the body try to do when we have pain around the joint? You tell me, you're the doctors. It tries to guard it and protect it, of course. And that causes hypertonicity of the muscles. Hypertonicity is going to cause an altered loading of the joint and the tissues. So we have a vicious circle where we have initial protection, but then we start to load the joint wrongly. And the longer a muscle is hypertonic, the more likely it is to actually establish these small trigger points, which are local irritation points. And sometimes you can massage them away, dry needle, or inject into them. Sometimes they're too resistant or too deep lying, so you can't get to them. And that's where, especially this device, focused shockwave, is very effective at relieving those. We also have for cartilage, osteoarthritis, especially at the hip and knee. There's been done some large studies which show in former control groups who receive pain medication and normal conservative treatment, it's superior with the focused shockwave to use that. And these are quite good quality studies here. Let's go in here. So, conclusion for this study is that it's more effective than known conservative treatment if you combine it with focused shockwave therapy. We also have a whole new study done at a medical hospital here, where they took arthritis of the first carpal joint. Probably all of you who are manual therapists already have some arthritis in there. I have in both thumbs. I had treatment on them, and they're fine now. And it showed that it was superior to injectional therapy, both short and long term. And they saw cartilage changes in the joint after 3 to 6 months. So if there's cartilage there, it can regenerate. The problem with cartilage is it has no nervous innervation, so it doesn't cause any pain. So why does one knee with osteoarthritis cause pain, while the other one that might have more does not cause pain? That's always something I wondered around. Why do some knees with osteoarthritis cause pain and some don't?
Inflammation.
Sorry?
Inflammation.
Inflammation, yeah. But why does inflammation come in one joint and not in the other joint? And sometimes when I scan, I will scan all my patients to see into the joint to see if there's inflammation. Often there's no inflammation, but it's still painful. And often I can scan the other knee, and there might be a little bit of inflammation, but there's no pain. That's a challenge, isn't it? So what the heck is going on in there? And that's probably what I'm going to try and give you my idea on during the lectures here on the knee, hip, and ankle, and what the newest evidence shows, what produces pain, and what do we have to focus on when we treat the patient. So, when we talk about tendinopathies, look beyond the tendon. When we talk about muscle injuries, look beyond the muscle. And when we talk about cartilage and bone, look beyond that. What's actually causing the pain? Is it the pain itself, or is it the function of the joint? I'm going to get into that in more detail here. Oops. So I just talked about that. So, how powerful are these tools? 4 years ago, I had to decrease my workload because I had inflammation and pain in both my shoulders, in my AC joints, because I was manipulating and lifting my patients around from daily clinic. I got both my shoulders MRI scanned and ultrasound scanned, and it showed calcification and degeneration of most of my rotator cuff. It showed inflammation and degeneration, osteoarthritis in my AC joints at an early stage. So I had a painful arch, and all the orthopedic tests were positive. I always tried to do some exercise, strength training to actually decrease that incident to occur, but it still occurred. I had 10 treatments with the Focus Shockwave, and after, let's say, 4 or 5 months, I was pain-free. I could treat and lift without pain, and I got scanned 1.5 years afterwards. And my tendons in the shoulder were like a textbook. There was no calcification. They actually regenerated to the normal size. I had no more osteoarthritis in my AC joints. So it's fully reversible, even at my age. So you can actually regenerate tissues if it's not totally worn out. If the cartilage is gone, you can't save it. It's gone. But still, we see joints, a knee joint, which has no cartilage and has no pain. So what's causing the pain? Probably some form of inflammation is causing it, especially inflammation which is actually stimulating the nerve fibers. So all of your patients come to you. Why do they come to you? It hurts. Pain, of course. So what is the patient most concentrated or focused on? Getting relief of their pain. Number 2 is they have some form of loss of function. They can't play football, tennis, or golf because they have a restriction and pain. So you have to try and rehabilitate the tissue so they can do that again. But you have to motivate a chronic pain patient. And you have to do that by modulating the pain within a few treatments. And if you use those 2 devices combined, you have a much better result. Because you are regenerating tissues in the long run, you are actually modulating pain straight away with both tissues, and you're decreasing inflammation by using both the Focus Shockwave and the high-intensity laser. So, and what now? The good thing is that with this device and this device, you can do a treatment in 15 minutes, and that's it. That's quite fast. In the old days, I had to use half an hour because the machines weren't able to produce the same energy. So, let's get into knee. What's causing knee pain? And which problems are most prevalent? So, I won't lecture you on how to do an examination, but there's a few steps which you have to actually go into. Especially active and passive motion, but most importantly, palpate. And if you palpate, you have to be specific when you palpate. I have big fingers, and sometimes I can't palpate precisely, because when I go into the knee joint and knee space, I'm not only actually addressing a ligament, I'm also addressing a joint capsule, I'm also addressing some bony tissue, and sometimes I can, let's say, palpate the meniscus underneath. So I actually use a little metal thing. You can use a metal spoon, and you can palpate very precisely to try and establish if the pain is coming from those tissues. And when you palpate, you have to communicate with the patient. You have to be able to actually reproduce the pain that the patient has. Because you can reproduce a lot of pain by palpating if you do it hard enough. But you want to find the pain which is causing the same pain that the patient actually came to you in the first place. All these tests for stability you have to do first to see if they have to actually go to the orthopedic surgeon instead of you. And then you have to go in and establish how much inflammation is here. You do that actually with passive motion, but you also do that by actually compressing the patella and grind it and palpate the different tissues above and below the patella and in the popliteal space too, to see if there's swelling in there. And then I would always recommend that you do some form of radiological work. If you are it's an acute injury, or if you are suspecting some form of bony lesions, get an X-ray. If there's some ligamentous tissues which you suspect ACL, which is ruptured or injured, get an MRI scan so you know what you're dealing with. If it's tendinopathies and inflammation, an ultrasound scan will be very good to refer to before you start treatment. So I always think practically, because I'm not that clever. I want to know what's causing the pain, because if I can find out what's causing the pain, then I can direct my treatment towards the pain. And the faster I can modulate the pain, the faster my colleagues can actually rehab the patient for me, so they regain their normal, like range of motion and activity level. So what's innervated by nerves, and what's most innervated by nerves? And we know that cartilage is not innervated by nerves. So that's not causing the pain. It's causing some functional deficits, but not the pain. The meniscus is only actually innervated in the outer fourth or third part, and not very heavily. We have very few nerve fibers in there. What's very heavily innervated are the ligaments. Like I said, the patellar ligament is very heavily innervated, also the ACL and PCL. And you can see the subchondral bone is very heavily innervated too. And before you actually see cartilage changes, when you do an MRI scan on a sportsman's knee, you see subchondral bone bleeding and bruising. And that's where the pain is coming from. It's not coming from the meniscus. It's coming from the subchondral bone. And it's not coming from the cartilage. So if you aim your pain therapy at a torn meniscus, 70% in the cases you will not have any good results. We've just done a very big international study on surgery for meniscus lesions, and about 70% of all surgeries for meniscus lesions should never have been done. It would have repaired itself. It's not causing the pain, and it's not causing the decrease in function. You only operate a meniscus if you have locking of the knee, or if you have a loose body in there. Otherwise, most of them will heal up by themselves and not cause pain interaction from the surrounding tissues. So don't guide your treatment there. It's old knowledge. It doesn't work. So think tendon, joint capsule, subchondral bone, and think what's lying in between all these tissues? Synovium. And synovium is very, very heavily innervated with nerves, and also with blood circulation. You know Piriformis Syndrome? It's just synovium and fatty tissue, and it's all surrounding the knee. And it's also often causing a lot of pain behind the kneecap. And we look at the cartilage and see it's irregular, it's run over, but it's not causing the pain, and it's not causing this dysfunction. So don't look at these areas, and don't operate on them. Try to actually decrease the inflammation and thickening of these synovial and capsular thickenings instead, and the pain will disappear. So don't think osteoarthritis, think about what's causing the pain, and direct your treatment there. Here we have a like the plica, surrounding the knee, not only on the medial side, but above it and below it too, and on the lateral side too. And when you start ultrasound scanning with a high resolution, you can see inflammation and thickening of these tissues. And when you try and compress them precisely, it will often reproduce the patient's pain too. And because it's so vascularized, the synovial tissue, it will react very fast to both high intensity laser and focused shock waves. It will decrease in thickening, and you will see a decrease in pain from the tissues and a decrease in inflammation too. So it's actually the synovium which is producing the liquid in the joints. That's actually what's causing these small protein chains, inflammatory crystals, which are traveling around, trying to stimulate the immune system to repair the structures which have been overloaded. So you have to decrease the chronic overload of these, or production of these tissues, or these chemicals, by actually targeting your treatment towards the synovium. Another overseen thing is that, have you ever, if you palpate really closely in a knee joint, then you have to palpate at the femoral condyle superiorly, you have to palpate over the meniscus and joint capsule, you have to palpate over the collateral ligaments and the patellar ligament, and you also have to palpate over the tibial plateau. And what holds the meniscus down and stabilizes it and is heavily innervated by nerves? That are these small collateral ligaments, these small coronary ligaments, which are actually reinforcements of the joint capsule. And every twisting of a knee, if you go in and palpate over the meniscus, some pain. If you go down over the tibial plateau, just where it attaches, that's where you will produce elicit most pain. So it's probably not the meniscus itself causing pain. It's these ligamentous attachments, which are always injured to in meniscus lesions. So direct your target these tissues instead, because you'll get very, very fast pain reduction from the knee, even though it's torn. So think, where's the pain coming from, and where's the lesion might lie? And you can see that on high resolution ultrasound, you can also see exactly where these small fibers are actually torn. And we see 90% of all meniscus lesions in the anterior and medial horn. And that's part of the meniscus which is mainly innervated, and that's also the one which is taking most stress in all kinds of flexion extension movements. So that's probably where you'll find most lesions. We see less on the lateral horn, and it's mainly associated with osteoarthritis, where we see problems there because inflammation have gone into that too from the joint. You heard about a Baker cyst? Yeah? And what is a Baker cyst? It's just that the capsule is weak in the popliteal space, so if you have increased swelling within the knee, it actually pops a little bit out. Do you think it's a good idea at operating on that? No. It will just cause more scar tissue. It's just a reaction that the knee has some damage inside of it, intra-articular. So forget about the cyst. You have to treat the tissues in the knee which are actually causing the pain. So, as I told you, palpate the attachments of the ligaments and the tendons, because that's often where the pain is coming from. I often have patients coming in, 40s, 50s, been playing tennis, and suddenly they have pain at the patellar tendon. And we can see that on ultrasound. It's swollen and it's hypoechoic, and there's some ingrowth of vascular vessels, and we can direct our treatment at that. But I also try to look at the surrounding structures, because you always have some form of swelling and adaptations in that too. So palpate, especially at the pole of the tip of the patella, palpate the pes anserine structure here. None of the attachments, we see very few injuries here, but we see many just where it actually lies just over the medial femoral condyle. It's a form of a frictional syndrome, just like the lateral knee where we have the tractus iliotibialis. It's not down at the attachment on the tibia, but it's just at the lateral femoral condyle where we have some frictional syndrome. The tendon is tender, and when you scan them, you will see some swelling in the synovial tissue underneath it. So you have to regenerate the tendon modulate the pain, and get rid of the swelling as fast as possible. We have a few clinical trigger points which are very valid, and the lateral stability is mainly associated with the tractus iliotibialis and the vastus lateralis, and you always find a lot of trigger point in those. And if you're not able to stabilize your knee laterally, you're gonna unload it in the wrong way. So always treat those trigger points too. And often with most knee injuries which has lasted for a longer time, you'll see deactivation of the gluteus medius, which is hypertonic. And you'll also see this trigger point here, which I would recommend you to treat. The rectus femoris, you won't see that many trigger points. You will see more small ruptures, especially football players and badminton players and tennis players. And you'll see them mainly up here beyond the musculotendinous junction, where they have swelling, and you can see palpable changes in the musculature. And they respond very, very well to both therapies here, where you can't use any other manual methods. Here we have a knee joint. It looks fairly normal, but if you look closely, you'll see in the x-ray we have some irregularities out here, some small bony spurs. And bony spurs is actually just calcification of the outer layers of the cartilage, just like the spine. So it's So why do we get calcifications? Why do we get bony spurs? Why do we get bony spurs in the spine? Pressure, yeah. It's probably small injuries that you have, and it's probably a normal process, because in the spine we see bony spurs in the anterior part. So the bony spurs are not causing any pain. They're just calcifications of the outer layers of the annular fibers. So when we talk osteoarthritis, many of these spur formations, are they clinically relevant? No, only if they're very big and actually encroaching joints. So don't focus your therapy on those. Look in here and see what's going on there instead. Here we have a lateral knee joint from one of my patients here. This is the femoral condyle. We see some bony spur formation here. This is a tibial condyle here. And this should be a normal triangular lateral menisc. It is very fragmented, as you can see here, osteoarthritis. This is the lateral collateral ligament coming down here. Due to the inflammation coming up from the joint from these small fissures here, we have a lot of synovial thickening and swelling, and we have some fluid lying out here, which migrates into the tendon and starts causing pain in these structures. So we actually have to treat these structures here instead of inside the joint here. And this is, as you can see, these are centimeters. They are only 2 centimeters down, and these 2 devices here can treat them very effectively in a very short time to actually get the pain away, reduce the swelling, and start regeneration of the tissues. So the stability of the joint is not the bone, it's the ligaments and the joint capsule. And most ligaments in the body are just reinforcements of the joint capsules. So if you have a ligament irritation or rupture, you will also have a little rupture into the joint capsule. That's why you get fluid out there. And many things that people call bursitis are not bursitis. It's just swelling coming from the joint capsule because you have an injury to these ligaments or these tendons which attach to them. Here we have the classical jumper's knee. Here we have the patellar pole and the patellar tendon coming down here. You see the nice fibrillar structure. Here you see a thickened one with small ruptures here and swelling, dark areas where the fibers have been undergoing some regeneration or scar tissue formation. Look at half a fat pad down here. Look at the structure and look over here. Can you see the difference? What we see with all tendinopathies in the lower limb is that where does the pain come from? When you palpate, have you ever tried when you palpate a patellar tendon and an Achilles tendon from P to A? There's some pain, but if you pinch them underneath, it's causing much more pain. Why is that? Sorry? Fluid accumulation, but it's causing pain when I pinch them actually. So I'm actually compressing some pain fibers. So if I press up here, they're moderately tender, even though I see the biggest lesion here, but if I press down here, it causes much more pain. Why is that? That's because normally this area here is not innervated very much by nerve fibers, but if you have an injury in them, in these fibers here, we see ingrowth of new capillaries and nerve fibers, C nerve fibers and alpha delta nerve fibers. And that's actually causing the pain when you press on the tendon. These fibers have grown in here, and because the repair process have gone wrong, they started creating scar tissue because you load them too early, or because the tendon is too degenerative. You actually have a loading. This tendon is filled with these C nerve fibers causing pain, but they're coming from down here. So many surgeons, they try to go in here and scrape and do things like that, and the tendon looks fine 3 months after, but they're still painful. That's because they actually haven't treated the pain area. So where I want to direct your treatment is actually in here. So you want to treat this area here. So you want to try and go in here with your Shockwave and get some regeneration, but you also have to treat the patellar fat pad. And you have to treat that. If you have both devices, you can actually cause retraction of these nerve fibers. And they actually decrease in size, and you can only achieve that by using this equipment here. Injectional therapy, like steroids, which I've injected many times, have a great effect for a few weeks, maybe a month, but they will all come back again. And if you give too many injections, they will weaken the tissues. So you want to do this non-invasively if it's possible. Here we have like the tractus iliotibialis. This is the lateral femoral condyle. You can see this is a normal, nice, homogeneous tendon here. Here you see the cartilage. This is a thickened irregular one, and we see some build-up here. It's not bursitis, it's just fluid production in the synovial tissue. And with these modalities, they react very, very fast. Even with the high-intensity laser, when I scan them and scan them afterwards, I can see less fluid in them. So it goes that fast, just one treatment. And you don't want to get rid of the swelling within the joint of the popliteal fossa. You want to get rid of the inflammation and swelling here. That's where the pain is coming from. So it's quite superficial, and with these focused shockwave devices here again, we use these gel pads to actually diverse or determine the penetration into the tissues. So you only need 5 to 10 millimeter gel pads to treat them there. And with these doses here, high intensity laser, we use doses between 3 and 6 watts for about 200, maximum 300 seconds. So it's a quite quick treatment time here. And with this device, you can actually fire 8 shocks per second. So within 5 minutes, you can treat the whole area with the linear device and follow up with a high-intensity laser, and you will have them both pain modulated, and they will have less swelling at the same time. And when you use the laser on top too, you'll get rid of the surrounding swelling in the surrounding tissues, which are also producing the pain. So osteoarthritis, don't think about cartilage and bone. Think about subchondral bone. And direct your treatment there. And when we look at ACL injuries, most of them are just, let's see, sprains, so we get a loose ligament in there. And because of the anterior and posterior, especially the anterior translation is controlled by the ACL, you get wrong loading, which the musculature cannot actually cope with in the long run. So you can put them in a brace and hope that this ligament can actually retract a little bit, but you have to do that for 6 weeks, and they're not allowed to use it at all. And most of them who've had small sprains have never had their knee in a brace. They've just been playing on, and then they suddenly start overloading the tissues and the muscular tissues surrounding them. The only way you can get this ligament to actually repair a little bit is by giving them focus shock waves. It's the only thing that can regenerate the ligament. You cannot do it any other way. Surgically you can do it. You can take out the old one, harvest a new one, typically from the biceps femoris tendon. It'll only have 10% of the strength of the original one. So even if you have a loose ACL, it's better to treat that than actually to operate them. And many of my patients who got an ACL reconstruction, they have a nice and functional knee and it's not unstable anymore when I do my stability tests, but they still have pain. And the pain is there when they stand too long, prolonged on the knee, or if they're out running and loading their knee joint surfaces again. In 10% of all ACL reconstructions, we get a kind of fault where the ligament is actually attached with a screw on the tibial plateau. While they're actually healing up, this screw loosens a little bit. So the ligament is still, after they've been operated, is still lax. They've done studies with 3 studies now here in Asia where they actually did ACL reconstruction. They screwed the screw down, and immediately while they were under the operating table, they gave them 1 shockwave treatment of 3,000 shocks, and none of these patients afterwards had that disability. We saw massive callus formation in the bone around the screw, so they didn't lose, so they healed much faster up. That's how effective it is. Just 1 treatment. And at the same time, because they actually targeted the screw, they also targeted the lower part of the ACL, and they saw, when they actually MRI scanned it afterwards, compared to the control group, that tendon had healed much better up than the other one. So you get a bigger and fatter tendon, and more cortex in the bone, and in some subcondylar bone too, to actually heal these patients up. Some patients post-operated also had pain in their knee. And then you can actually use this device as a diagnostic tool. So you can actually target first the meniscus, the femoral condyle, and I'll bet you if you go down to the subcondylar bone on the medial side, on the tibial plateau, it will reproduce the pain. It's because they have subcondylar bone swelling. And that's causing the pain. So if you target them with 3 treatments, you will see that these bone edemas will disappear after 2 to 3 months. The pain will go away because that's where the pain fibers are. They're positioned just in the subcondylar bone between the cortex and the other bony tissue. So always try both with the laser and the focused shock waves to bring the structures that you want to treat as superficial as possible. Here you see I'm treating a patella pole. So I have them lying like in 90 degrees flexion. Here I'm treating the pes anseris, just over the lateral medial femoral condyle. Here I'm treating the tibial band over the lateral femoral condyle. That's where you have to target your therapy. And I have the same position when I use the laser beam tube. Oops. Turn here. Okay. Just to demonstrate that in practice, does any one of you have a knee problem that I can treat? We have a person here. Let's get your hands and your name. Pete, let's give Pete a hand. So we'll do a very fast examination and case history. So which knee is it? And how long have you had the pain for?
3 years.
3 years. And how did it start out? Did you have an injury or? Badminton too much? Okay. And the pain, is it on the front, on the medial side? It's medial? Okay. Have you had any swelling? You had swelling too? And what causes pain now?
Standing up too much, walking too much.
Okay. Classical knee pain? Medial anterior knee pain? 3 years? Probably associated with too much badminton. And now associated with loading and use. So let's try and get this equipment and work with us while we examine the patient to find out what's actually causing the pain here. Because when we know where the pain is coming from, it's much easier to actually tell you what you're allowed to do and not to do, and then it's much easier to rehabilitate the knee. So which exercises are good, which shouldn't be done, and where should we target the therapy at. So if you take your trousers off for me, I'll just see you here, yes. Perfect. If you come up here in line, on your back for me. So, I'm just going to put this down here. Can you all hear me?
Yes.
So, I'm going to do this very, very quickly. So, we just do the inspection and the swelling from the side, front, and back, things like that. We do a quick active and passive. You already told us what's causing the pain. running, jumping, walking too much, causing the pain, so we're loading the joint here again. We have a little bit of varus deformity of the leg, but we have that of both legs, I can see. So I'm just going to see if there's any pain when I extend the knee. No problem. We flex the knee.
Yes.
Yeah, we have. And where is the pain? Right there. So we're going to take the knee and just test the stability of the knee, ligamental structures. And we're just doing the ACL. Just grossly PCL. And relax here again. Okay, no go slowing. So we're going to try and palpate the patient. I'm going to palpate over the patellar tendon. Any pain here? No. We're going to do the joint capsule. So we're going to do the medial side. Any pain here?
Mild.
Mild. I'll come out here.
More.
More.
Hurts.
If I come down here. More here.
Yes.
So here we are on the tibial plateau. I go up to the femoral plateau. Pain here.
Tibial plateau the most.
Tibial plateau the most. We're just going to go lateral here. Any pain out here?
No.
Tibial plateau.
No.
And up here. We're just going to do the patellar wash, and that's mainly to hear if any. I don't go for crepitation, I go for pain. And I go for swelling around here, so I compress the synovial tissue, the plicus here. Any pain here?
Mild.
Mild pain? Okay. So there's also some mild pain underneath there. Is that the same pain mechanism spreading in the joint, or is it a different anatomical site that we have to treat too? We don't know. So I'm going to just come back here and palpate in the popliteal fossa. Any pain here? I'm just going to palpate here in the vastus medialis.
Mild.
Mild pain.
More. More.
And we have a nice little nodule here. If I compress this, does it radiate anywhere into the knee?
Yes.
Classical trigger point, lying there. Just going to take this here off. So will it be first line of treatment? Wouldn't be the trigger point. It would be the more painful structures. We do the vastus lateralis out here. So we go in deeply and press here.
Hurts.
Okay.
Sorry. Is the trigger point is the same pain?
Normally the myological pain pattern for the vastus medialis will go down over the kneecap. So you'll have a diffuse pain, anterior knee pain. So if you don't have it, have a Terrell and Simons little poster in your room, and you will know the myological referred pain here. The vastus lateralis, so I go above the joint line, I go in here. I normally always find some trigger points in here.
It does.
Okay. And if you hold them in for a long time, it's radiate anywhere the pain.
Thank you.
No, everything is good.
It normally gives lateral knee pain and ankle pain. And when you have a knee or a hip pain, because both joints are actually innervated by branches from the femoral nerve, the obturator nerve, and the ischial nerve, you sometimes can have referred pain. So a hip problem can give knee pain, and a knee problem can give hip pain. So you always have to just rule those things out. So always do a full examination where you do the low back and the hip area too, before you go into the knee here again. So we have some problems in there. So what I would like to do now is I'd like to try and diagnose with this device here to see if I can elicit the pain that the patient actually has. So we take this device. How many of you work with the focus Shockwave? A few of you? Yeah. So we have a gel pad here which says 10. That means that the beam of the therapy area is aimed about 10 millimeters down the tissues. And normally I scan the joint and I measure how deep the different tissues are. But normally with this kind of joint, I know by experience that a 10 millimeter gel pad will actually target all the different areas that I want to target in here. So I want to actually search around this area to see what elicits the patient's pain. So we put some gel in here. A little bit more.